Oh, thank you everybody for taking times out of your busy days. COVID has changed all of us for sure. Made veterinary medicine a lot busier than we probably may have planned, which is a good thing, but we also need to support our team, help out with everybody, and also be able to help all this influx of new patients. So I want to kind of walk through today some of the things that I look for in diagnosing arthritis, things that even before I was a diplomat or working in a specialty hospital, I did general practice for many years. So things that we can pass along to make things hopefully a little bit easier for you. I'd like to thank Assisi for hosting this and for that warm introduction. They did a much better job of introducing me than I sometimes do of myself. These are just a little bit of the emblems along the way of some of the places I've been and where I am now in Northern Virginia. I'm very lucky to be with an amazing team here. And I realize that it's October, and if you're not a member of the IVAPM as a veterinarian or a veterinary technician, I really recommend that you do. The International Veterinary Academy of Pain Management is a great and wonderful resource that you can use, including this poster that we print out and put in our exam rooms all year round, not just focusing on September as Animal Pain Awareness Month, but just as a good conversation starter. We use this a lot to have owners start to think about what's not right with their pets at home. And then our COVID-19 edition of this is we started emailing this out to our clients to have them think about it. We posted it on our social media. So we found a different way to engage and start conversations with owners about problems that they may not be fully aware of in their pets. What we'll cover here, we're going to quickly go through pathophysiology and diagnosis, and then I want to get into a couple of the different treatment modalities. Most of the pictures along the way are all of patients of mine. This owner sent me this picture of her bulldog a couple of weeks ago. She was super excited because we've been treating this dog for bad hips and bad elbows. And she was super excited that he was able to and eat out of the high chair, to which we then had a conversation about his weight gain since I hadn't seen him in a while. So owners will perceive happy things, but we also need to be aware of the whole picture as we go. Do we get taught a lot about osteoarthritis or OA or DJD, degenerative joint disease, in vet school or in vet tech school? And then the answer is no. We get a couple of basic understandings of it, but it's something we wind up really focusing on a lot postgraduate work because we see so much of it. A couple of research papers that are out there that everybody kind of quotes for the last 20 years or so, looking at anywhere between 20% of adult dogs and 60% of adult cats have radiographic evidence of arthritis. But sometimes we find arthritis incidentally. We take some x-rays because they have abdominal pain and we go, wow, you have really bad hips. But the dog walks 3 miles a day and doesn't take pain meds. So sometimes radiographic doesn't always correlate to clinical exam. But when they polled owners, 31% of owners said bone and joint problems were an issue with their pet. So for these nonverbal patients, we're using other ways to tease that out from either radiographs, owner surveys, or functional tests that we can do with these patients to tease out where, are they having a real problem with their mobility? And OA has been identified as the #1 cause of chronic pain in dogs in the US. And if it affects 1 out of 4 dogs, that's roughly 20 million dogs nationwide. So the impacts are pretty obvious, right? You get chronic pain, decreased activity, negative impact on the patient, a negative interference with that human-animal bond that we all want to have a positive one with in all aspects. And ultimately, sometimes enough chronic pain that we're dealing with euthanasia. So how can we avoid that? We still understand more. It's not just in the US. This was a study out of the UK that looked at frequency and clinical management of elbow arthritis in dogs there. And again, very similar findings to what we find in the US. 20% of them had difficulty exercising. 3 out of 4 dogs in this study had lameness. 1 out of 7 had pain, just looking at elbows. And what are some of the risk factors? Older age, okay, they've had more wear and tear on their joints, being neutered. And even in the UK, they don't neuter or spay nearly as much as we do in the US. Bigger dogs, okay. Being male, maybe one factor. Being insured, and that's an important factor here. In the UK And in Europe, they have many more animals that are insured from the get-go. So they have a different perspective, where in the US, we're only averaging about 2% of pets nationwide have insurance. So a lot of times these are out-of-pocket things for owners. We're going to have to really plan and budget accordingly. What does that mean? It's not just the US, it's not just the UK. We have to think about it as a global disease, but also as a global disease in that patient. Arthritis is the final pathway of a failing joint. Bone-on-bone contact is something we all want to avoid, but you have to look at the whole patient. You have to be able to see that it's not just the articular cartilage, it's how does that impact how that patient then uses its legs? Is it able to stand up? What stresses does it put on its other parts of its body? And how does that then impact its ability to walk? And if they're not walking as much and they're not active as much, but the owners are still feeding them the same, now they're getting fat, which doesn't help their activity even more so. It only makes things worse. If we zoom in on this and we look at the joint itself, it's really those pro-inflammatory mediators. And not to get into too much of this, but as we get that inflammation and that synovitis, right, the synovial membrane is what provides the nutrition to the joint. So if the synovial membrane gets inflamed, we get increases in macrophages. We then get thickening of the subchondral bone. And what we ultimately see is the end. It's the osteophytes. But way before that, on a microscopic level, that joint is damaged. And so these pro-inflammatory mediators that cause this come from joint instability, so joint dysplasia, right? That laxity of a joint or that incongruency of an elbow joint causes inflammation. And then we've also shown that adipose tissue, fat, releases pro-inflammatory mediators. So not just being fat does that put more weight on the patient's body, but at a microscopic level, it also causes more joint damage. And then ultimately it becomes that vicious cycle. We loop back to the osteophyte, it puts more stress on the joint, causes more inflammation, and continues that cycle. So when we treat that, what we have to do, because it's not just at the level of the joint. We said it's a global disease within that patient. When you have those nociceptors that are inflamed in the joint, that then signals the brain through the dorsal horn of the spinal cord that there's pain involved. So not only in the joint do we have a problem, but we have to think about treating the body as a whole. And here's just that example of that vicious cycle, right? Whether it starts with dysfunction, we then lead to structural changes in the patient, then leads to sensitization of the nervous system and just more and more pain. You can pick up a patient anywhere with this. One will then start the other. So structural modulations can happen because they tear their cruciate ligament. And now we get into all this cycle. They were born with hip dysplasia and laxity, causing these problems eventually down the road. And so if you start to think about that, how can we understand where it's affecting the whole joint? The normal joints on the left side of your screen, the arthritic joints on the right, and it's just the complete opposites, right? We get a thickened synovium, inflamed amounts of fluid, thinner cartilage. It's just not a healthy environment. But just because we don't necessarily see big osteophytes on radiographs, if we could pop an arthroscope into every joint, we probably would find more changes earlier on, because the osteophytes are just the last thing that we see. That's what we can appreciate on radiographs, but the changes are happening ahead of that. And really think about arthritis as a synovial disease. The synovium provides the nutrition. And if the synovium's not happy, then it's not going to take care of that joint. So if that synovium gets thickened, it then increases its macrophage count inside the joint. Those macrophages are just degrading things left and right. Those cytokines that are pro-inflammatory mediators are then just creating more and more of this slow burn of that joint. But we don't see the synovium on the radiographs. We only see the end stage. So we have to be better about diagnosing arthritis earlier. And when we do that, we have to think about these. In dogs, most of the time, arthritis is secondary. So secondary to obesity, secondary to hip or elbow dysplasia, cruciate ligament tears. And any problem that involves or disrupts the joint will lead to arthritis. So, it's the dog that gets a migrating grass on through its stifle joint is going to cause some cartilage damage. The dog that has any sorts of problem like that will get those. Cats get primary OA. Dogs really get secondary. Cats just simply get primary osteoarthritis, not from joint laxity. Right? We don't see that many cats with hip dysplasia or elbow dysplasia. They just simply wear out their articular cartilage as they get older. A little bit different disease process. What do we see in our diagnosis? This is where our vet techs come in, our assistants, because you guys are going to tease this out in the history for us. So they come in for a general exam, their annual wellness, and tease it out and go, when was the last time they went upstairs? How long do you go for walks? Are they stiff? Are they sore? Are they not doing as much? Cats, remember, are not small dogs. And aggression, unkempt appearance, reluctance to jump, and reduction in activity are not the only telltale signs for arthritis in cats. Those are also the telltales for chronic kidney disease or lymphoma or any other thing. So those are kind of very generic for cats, but it makes us start to think as a veterinarian better about being a diagnostician and finding out what's going on. Because age isn't the disease here. It really is the fact that something else is going on inside the body. We need to be better about listening to hear it. On our orthopedic exam, dogs are going to have muscle atrophy, joint swelling. They may have capsular or extracapsular fibrosis, which is, remember, if you have stifles that have medial buttress, well, that's fibrosis. So you can see that in other joints as well. They're going to have reduced range of motion, and they're going to have crepitus and pain. How do you get good if you're just a new graduate or recent graduate, or you say, I don't like mobility disorders? How do I get better at diagnosing them? Feel every joint on every patient. If you know your normals, then your abnormals are going to stick out really easily. So for example, I bend and extend every elbow when I was in GP. I bent and examined every stifle, every hip, every hock. I learned what was normal, and I could feel the bony prominences. I could find the concave areas of those joints, so that when those joints were not concave, if they were flat or really severely convex, I knew that they were effused. Cats are a little bit harder. Spend more time with cats, slow things down. A lot of times I'll just put a cat on the table and put its carrier down on the floor and see how it jumps. Does it think about jumping? Does it freely jump? Does it land with a thud? And then I'll reverse it. I'll put the carrier up on the table, put the cat on the floor, and see, can it make a jump of a reasonable height? And then part of that diagnosis of arthritis, because none of us were born with X-ray vision, is we have to take radiographs. Radiographs have their limitations. They may only show bony information, of course. They're not going to show the cartilage. They're not going to show the synovium, but they still give us telltale signs to diagnose osteoarthritis. Yes, they're not in weight-bearing positions. Yes, they don't always correlate to clinical disease. But if you have a problem, you think it's arthritis, take radiographs, because about once a month, I get in a case that has arthritis, in air quotes, and they've never taken radiographs. Now, sometimes that's not on us as a veterinary healthcare team. The owners have declined it time after time, but at least offer it. Because I get about a case a month of quote unquote arthritis that's actually a tumor that's eaten away the joint, or a hairline fracture that somebody missed for a while. I find all sorts of weird things. And those are challenging because it may feel like elbow pain, and most of the time it's elbow dysplasia, but it could be a synovial cell sarcoma. And that's a vastly different treatment and outcome and prognosis. So we want to be good advocates. I tell owners all the time, I'm not Superman. I wasn't born on Krypton. We need to take radiographs to find out exactly what we're dealing with. When we take those radiographs, what are we looking for, right? Stifles are a big one, right? Anytime you have osteophytes in a stifle, there's something mechanically unstable in that stifle. So if you find stifle radiographs with osteophytes, go back and look for an MPL or an LPL or a cruciate ligament tear. There's something going on, right? If we find these radiographs, we can look here. This green arrow up at the top right, this is all arthritic change along the trochlear groove. We have some notching here and osteophyte formation at the caudal pole of the patella. We even have some osteophyte formation here on the caudal edge of the tibia. And of course, we also have displacement of the fat pad and intra-articular swelling. All of this gray, diffused, brighter areas, all swelling, including, remember the knee has a caudal component. All of this is also joint swelling. Right? So these are things we can start to look for with these. I usually take radiographs under sedation. Reason is it's safer, you can get better positioning, and it also allows me to feel those joints when that pet is unconscious and protected by analgesics. So we can get a better understanding of, are they unstable or not? Does that hip pop out of socket? You know, does that cruciate, is that knee that's arthritic, is there an unstable cruciate in there that maybe needs to be addressed through surgery? It doesn't help everything. So what other things is my diagnosis can I use? Well, if we went through mixed animal in vet school, we did a lot of equine. And so I take those same examples and I watch dogs walk in the hallway, or I go outside and I watch them how they walk on the sidewalk. I take muscle mass measurements and I do goniometry where we measure the flexion and extension angles of every joint. And we start to see what can really be put together. We get some cheap, objective, numerical data that we can do, but we still have nonverbal patients. And we're only seeing them for an hour once a week or once a month. So what other subjective assessments can we get from this? We can use the Canine Orthopedic Index. This was developed at UPenn's vet school a couple of years ago, and it was designed and validated to provide reliable assessment with dogs with OA in terms of staging. And it's free. Go and you can download it today and use it in your practice. Right? It's a simple thing to have owners fill out. You can have them fill it out once a week, once a month, whenever they come in. Hey, how's the last couple of days been? What's going on? And this is a helpful tool for them to answer some very simple, I think it's about 10 questions or so, on stiffness and gait and how they've been better. And then you can take that and you can compare it to when it was a month ago. And you can say, wow, not only do we think the dog is moving better as we watch it today walk in the exam room, but we start that profile and your answers went from can't barely do anything to doing everything at home that you want them to do. That helps us to understand that our patients are getting better. It also helps us that if we're getting the same answers, maybe the therapy that we're doing isn't working. So as we diagnose arthritis through our physical exam, our history questions, canine orthopedic index, and our radiographs, now we move into treatment options. And treatment of arthritis is always management, okay? There's very few types of arthritis we can cure. And in this case, we're only talking about osteoarthritis. We're not getting into autoimmune diseases. But the only way we cure arthritis is to do a joint replacement, right? So we can cure arthritis by doing a total hip or a total elbow. There's even total tarsal coming out soon, okay? But other than that, we are managing these, which means we're going to see them on a regular basis. And we're going to have some trial and error about what works for that individual patient. And we're going to take what's called the multimodal approach, which means that there's not one magic little pill that solves everything. So we may get them on an NSAID. If they're fat, we need them to be skinny. We need them to be lean. We're going to protect their cartilage. We're going to get them involved in doing exercise. We're going to try to find a way that works best for this patient, this family. Management can be broken down into the ones that have a primary problem, and they're going to develop OA, right? So we know that if a dog has a ruptured cruciate, we know we're going to get arthritis. We know that a procedure like a TPLO will basically stop that arthritic progression. We want to help that. We may also get the patients that just come in and say, my dog doesn't walk as well. It's not unstable, but it's painful. So those are our OA consults. We have to figure out, where do we go? We start to put those together, we diagnose them, then we sit down with the owners and go, how do we want to approach this? Do you want to take pills every day? What happens if your dog can't take pills? Has liver disease, has kidney disease, can't take an NSAID? What other options do we have? But to be honest, the NSAIDs are our cornerstone of therapy. Arthritis is an itis. It's an inflammatory thing. So we need a quick acting anti-itis. And our NSAIDs are our best way to get relief. When that patient's limping on a Friday afternoon, they're going to feel better by Monday on carprofen or daracoxib. If you start a joint supplement that day, they'll feel better 8 to 12 weeks later. Okay, joint supplements don't kick in overnight, and they're not a true one-for-one correlation to an NSAID. And NSAIDs work in wonderful ways. They work at the level of the joint, they work at the level of the dorsal horn, and they work at perception of the brain. So when you give that systemically, it's not just affecting that arthritic elbow, it's actually toning down the perception of pain in the brain itself. But what other options do we incorporate into this multimodal approach? Well, diet and exercise, right? Those are our biggest ones. So if they're fat, they need to be skinny. Dogs really can do this through, us as veterinarians and veterinary technicians working on diet. How much are they eating? What type of food is it? How many cups? How many calories? How many treats are they getting? Especially with COVID, they're home more. Oh, here's a treat for doing this. Holy cow, that little Chihuahua's eating 800 calories a day. No wonder it can barely waddle down the street. Remember that running around in the backyard is not exercise. That's sprinting for a few seconds. That does not burn calories. Okay? So we have to get these guys out doing regular exercise, burning through their fat, and yeah, check them. Not that there's a pandemic of hypothyroidism in dogs going around, but hey, if they want to check into thyroid values, that's a good idea, because this way it also puts on paper that, hey, your CBC, your CAM are all normal, your UA is normal, your thyroid panel is normal. Your dog's fat because you feed it too much. That's what I can tell owners. I'll rule out thyroid all the time, because if it is hypothyroid, it's also a quick and easy fix usually. So look into these, get a good perspective about what's going on, because otherwise you wind up with a dog like this, right? These are not photoshopped. This is a 57-pound dachshund that came in to see me last year, okay? Dog was eating over 2,000 calories a day, right? They brought him in as a down dog because they thought he had herniated a disc. When we actually did his neuro exam and his ortho exam, his joints were under a lot of stress, but he was all normal. He didn't have cruciate tears. He didn't have elbow arthritis. He had normal placing and hopping with no spinal pain. And he could ambulate when we got him off the ground and supported him. He was just so fat, he could not stand up anymore. And that's kind of sad, right? We don't want this. These folks had thought it was cute for a while. They got him his own Oscar Mayer Wienermobile. He had stopped being able to walk. His walks were them placing him in the grass to pee, lifting him out of his own pee, putting him in the Wienermobile and walking around the block. We ran full blood work. This dog did not have hypothyroidism. This dog did not have any other issues other than getting 2,000 calories a day. And we are working with him to lose weight. And while it's theirs, because here's the honest answer. This study came out December of 2018, and you can go out and find it. It's in JVIM, which is an open access journal. So anybody can read this from start to finish. You don't need a subscription. And they looked at 50,000 dogs and said, is your BCS ideal or are you over-conditioned? And then how long do you live? And on average, look at the center of the screen. Fat dachshunds live 2.3 years less on average than their lean-bodied counterparts. And if we go back to what I said at the beginning, arthritis will affect the human-animal bond. If your dog doesn't live as long, that bond is not sticking around as long. So I advocate to get these patients to a normal BCS, right? For all the reasons we've talked about in this presentation. Look at these different breeds, right? We're talking significant chunks of their lifespan diminished. If they're obese, they're just not going to be around as much. We talked about some of the impacts of obesity, not just the mechanical stress and strain of carrying around extra weight, but also that the adipokines that are secreted by white blood cells are directly pro-inflammatory. On a microscopic level, fat causes cartilage damage. We have to get through this together. So we work on weight loss. Well, do we have papers to back that up? Yes. Human increased body mass index that have OA, when they lose weight, they have less problems walking around. We have papers to back that up. We even have that in dogs, right? Weight loss reduces the signs of osteoarthritis in dogs. Preventing obesity decreases the incidence of osteoarthritis in dogs. So yeah, sometimes we just need this in writing for those people, that's fine, but be good advocates of minimizing obesity. And then we get them into physical therapy or rehabilitation. We do it through our modalities. We may work on pain through laser therapy and ultrasound. We may do manual therapy like joint mobilization and massage, and we work on therapeutic exercise, right? Anybody want to guess? I know it's not an interactive one, but anybody want to guess real quick the age of this Cavalier King Charles, who, by the way, does not have heart disease and does not have syringomyelia? Okay. This dog is competing in significantly high levels of agility. This dog is 13 years old. Okay. He has some arthritis. He worked with our rehab department and he is flying through his competition still. Here's my own dog and me working on our balance, right? I've got her upright. This is advanced core exercise work. But this is what we're trying to do with rehab, is maintain and improve muscle mass, build muscle support around the joint, reduce pain, and when indicated, reduce the chubbiness. How do we do that in rehab? You can do rehab tomorrow at your clinic, right? You should go out and get trained if you want to really pursue it more. But you can all be good advocates. You do a good assessment, measure some limb girth, some muscle mass, and we assess a BCS on every patient at every visit. We weigh them on every visit, at least once a week. If they're coming 3 times a week, I usually don't weigh them that often. But let's figure out and be advocates for this. And we tailor a program specific to that pet that includes in-clinic work and also includes home buy-in. Because if the owners aren't on board, it does not matter how many times a day we make them come in and spend money in rehab. If they're feeding them extra calories and not exercising them at home, we are not going to win in a battle of arthritis. What's our fundamental therapeutic exercise for managing arthritis? We talked about it. Walking, not running, not chasing the frisbee, not playing fetch, walking. Get out, non-slip surfaces, no crazy leashes. We want nice, easy, non-elastic, non-retractable leashes. And get out and start with a 10 to 12 minute walk a couple of times a day at a normal pace for the pet. You know, and shouldn't be stopping every 3 seconds to sniff. They also shouldn't be galloping to keep up with you. So if it's a little Chihuahua, walk at the same speed as if you would walk your grandmother down the street. As we build on that, we're going to add 3 to 5 minutes to every walk every week. And we're going to start to add in some other things along the way in their management. We figured out what their problem was. We've gotten them on some NSAIDs maybe. We're working on weight loss if that's appropriate. We're working on some therapeutic exercise. Now is when we can start to then add in other things down the road. Maybe joint supplements and omega-3s. I use atticon in dogs and cats as well. So we want to find out where we need the least amount of pain meds, the most amount of benefit for the patient. So that my goal is to not have them take pain meds every day for the rest of their life. But what OA management is not should be, here's your NSAID and here's your tramadol, and that's all we can do. We try to get them to their lowest frequency of NSAIDs until their end stage. And opioids are really not designed for chronic use. So OA is chronic pain. Right? Tramadol, I'm going to show you a paper. Right? We're going to show that that's of no benefit. And we're going to recheck these patients. So I don't see, even when I was in general practice, my OA patients I saw every 3 to 6 months. They're older. We're usually be seeing them twice a year anyway. If they're younger, you have a better control of them. The owners that have that bino come and participate in your clinic. It's beneficial for the patient, beneficial for the owner, and beneficial for the practice. Here's the paper straight out of JAVMA a couple of years ago on why we don't use tramadol. Right? Tramadol as a single agent for dogs with arthritis was less effective than placebo in a gait analysis force-placed study. Okay? Tramadol doesn't work, right? It's not going to be a standalone. It's not even that great as an adjunct into managing arthritis. Things that could be helpful: PS gags, polysulfate glycoaminoglycans. Atticon's one of the trade names for this. Off-label, you can do it sub-Q, so I can usually teach owners how to do it at home. And if they can do it sub-Q, we can also do it in cats as well, sub-Q. So I have a lot of my owners that if they're early, if their OA changes are mild and we're adding an atticon to diminish the amount of NSAIDs that they're using, I start with this and we have them do it at home twice a week for 4 weeks, and then about once a month or so. Some other adjunct analgesics can be amantadine, which is one of the few that we actually have a research paper on, showing that in conjunction with an NSAID, we can help manage their arthritic pain. And gabapentin, We have a really wide dose range, as you can see on the slide, and we have 0 papers on gabapentin for efficacy of OA. So all of it's anecdotal, and that's not necessarily bad in veterinary medicine, but don't just trust it that it's going to absolutely solve every patient. Some other adjuncts that we might use: can use Tylenol in dogs, you can, obviously not in cats. Codeine, uh, not that helpful really, and now we're thinking that it needs to pass through the liver in order to really be absorbed, so not one of my go-tos. If anybody's using Grapaprent out there, remember please that it's still an NSAID. It still needs to be given daily, every day, permanently. It's not a PRN drug like carprofen can be. It does need to be given on an empty stomach for proper absorption. And there are about 9 cases of acute renal failure on the ACVIM listserv directly attributable to this drug. So still treat it like any other NSAID, still get blood work and urine before starting it, and regular blood work and urine monitoring like you do with any other NSAID. But what other things can we do at home, right? What can owners do at home if they can't come into the clinic as much, if your schedule is just that busy, or they can't take those drugs, especially in this COVID pandemic? What can we do? My big reach for that I like a lot is PEMF therapy, pulsed electromagnetic field therapy. Kind of looks like an old TV antenna of sorts, but it's actually safer than 1,000 cell phone batteries. And PEMF is that TPEMF is much more appropriate because we want that targeted pulsed electromagnetic field. When we use that, that's the Assisi loop, and what it does is it regulates and modulates nitric oxide through the signaling pathway. So when it does that, we're directly decreasing the inflammatory process that's going on inside those arthritic joints. The mechanism of action is that it enhances the nitric oxide signaling. That will then help to signal pathway those patients, and it leads to increase in blood flow in that area, a reduction in pain and inflammation. And the original device was actually used in the 70s and 80s. You had to be hooked up it for like half a day, and it was used for progressing malunions to heal in fracture cases. They then miniaturized the technology and were using it in women going through breast cancer surgery and showing that they had decreased pain, increased mobility, decreased scarring. So it's one of the few devices we actually can use over cancer. So I don't use it just for arthritic pain. I use it for a lot of different pain. And the benefits to the patient is that it's a non-oral way. So if we have organ dysfunction, we have other things, it's another way that we can just attack the problematic area and not affect the whole body systemically. And it's FDA cleared for use in humans and in pets. Here's an example of just using it over an arthritic sore area here. Treatment times are about 15 minutes. So the device is the one here in white. The battery is encased within here. The electromagnetic field is emitted through the loop, and it winds up kind of looking like it emits in both directions. So it kind of looks like a football, or more appropriately, since we're all in vet med, it looks like a whipworm egg, right? So field, so you can place it over an area. I can place it between both knees and treat both knees at the same time on a lot of patients. You can place it over the LS area and treat the LS and both hip joints in a lot of patients at the same time. Treatment time is 15 minutes. There's been papers showing that in the acute postoperative phase, we can use it every 2 to 4 hours at the same time as cryotherapy. We can also use it in the chronic phase, where it's maybe 1 to 4 times a day, and it'll penetrate through bandages and cast material and bedding. We just don't want to use it over pacemakers or in metal cages because it's an electromagnet, which I got one step ahead of myself with my own slides. Do we have any research on it in veterinary medicine? Yeah, we do. This was out of Jaha about a year and a half ago. This was out of the Animal Medical Center in Manhattan, looking specific at postoperative hemilaminectomies in a double-blind, randomized, placebo-controlled trial, our gold standard of trials. And they showed that the patients getting the Assisi loop therapy needed less opioids postoperatively and less opioids at home. And also these dogs had better incision scores. What does that mean? Incision scores means that the skin healed better. And incisions usually heal pretty well anyway, but if we have decreased scarring, It's also a good advocacy to use on those patients that have slow healing wounds. So that pain in the butt dog who chewed out half of its stitches, right? You have to clean it up, debride it, maybe it's healing by second intention. Let's put a loop on that and help that to minimize the scarring there. Let's use it on degloving injuries as well. Things that we can help to accelerate wound healing. Here's another paper on this device using it in postoperative pain and locomotor recovery in dogs following disc surgery. Again, randomized, placebo-controlled. Another really good paper showing that they had better outcomes with the loop than without. So those benefits, we can use it over implants. We can use it in cancer patients. We can use it at home, right? Do we do this a couple of times in the clinic? Absolutely. But this is a device, especially during the pandemic, that I can have owners treat them at home. And if they have lots of sore areas and you're like, man, I have to treat the hip and then the elbow and then the back, they make a nice rechargeable bed that actually has 6,000 treatments in it, because each loop probably is about $250, $300, and they each have about 150 treatments. So it's about at twice a day, it's a 7-week supply or so. But those treatments come out to about $2 a treatment. The rechargeable bed that we could fit the whole patient on has 6,000 treatments. It's about $1,000-ish. So it comes out to 20 cents a treatment. It's a lot more beneficial. But what I recommend doing is starting with a loop, seeing that the patient sees improvement, that you see improvement as a clinician, that your owner sees an improvement, and then moving forward towards the bed. We want to make sure they're going to respond to it first. In summary of treating arthritis at any point, but some tips and tricks along the way through this pandemic: treat early. Be proactive instead of reactive as much as you can. Take your radiographs, get your diagnosis. Remember that things that owners can do at home if they can't come in as much, they need to be walking their pets. They need to do home exercise. They need to work on weight loss. We need to work through that multimodal approach. And a CZ loop is another great device to use at home for those owners to help participate in their pet's management of their arthritis. If anybody's looking for updated pain guidelines, remember that the American Animal Hospital Association puts these out every couple of years. I'm going to bet that they maybe got delayed this year with the pandemic, but hopefully the new updates will come out in the next year or so. And remember that it's a multimodal approach to managing arthritis through all these different pathways, including surgery. Sometimes things don't always progress and do well, but we can go to surgery for these patients and help them as well. Resources along the way for working with pain and working with arthritis. Here's a couple of websites you guys can grab screenshots of. And here's my direct contact info. So I'd like to thank everybody for taking time out of their busy schedules to either watch this as it happened, or if you're checking the recording later on. Like I said, I'm in Vienna, Virginia. So if anybody has questions or consults about patients in the DC area, I'm always happy to help out.